Okay. So, essentially, the topic of my today's discussion is there was a case which is given to me, and the case suggests that this is a 75-year-old gentleman, diabetic, with cancer prostate. The stage is pT2N1. The patient is obviously post-radical prostatectomy. The patient is referred for radiation therapy after 3 months of surgery. So what is the role of radiation, if there is any role of radiation, and if there is role of radiation, then when and how it has to be given? So we'll discuss this topic. We'll dissect this case into various aspects so that we can understand what are the kind of patients which require radiation, which require radiation in adjuvant setting, and which require patient in salvage as a salvage therapy. So starting from the discussion. So adjuvant radiotherapy in cancer prostate. So Nilesh, can you tell what do you understand by adjuvant radiotherapy?
Yeah, when there are certain indications for post-operative radiation prostate, like cut margin positivity, gross extra prostatic extension, or lymph node positivity, we would advise giving radiation.
I want to understand when.
Yeah,
I want to
so
understand
the ideally in all solid cancers, we do it at 4 to 6 weeks from surgery. But in case of prostate, it being a slow-growing tumor, and there is issue of urethral strictures, anastomotic strictures, so we delay it to at least 3 months in adjuvant setting.
Okay, Dr. Maulik.
Yes.
Any comment about when?
Yeah, adjuvant, according to guideline, we can delay up to 12 months, I think.
12 months.
According to 12 months, according to patient condition and resolution of the urinary complication post-op.
Okay.
So
okay,
ideally, it should be after 3 months to 12 months.
Okay. Dr. Priyamvada, any comment about adjuvant radiotherapy?
Generally, for prostate cancer, adjuvant therapy would mean doing it in the post-op period without a rise in the PSA. And that makes it distinct from the salvage radiotherapy, which is done when the rise in PSA is seen in the post-op.
I want to understand the duration. Adjuvant radiotherapy means till when you can define radiotherapy as adjuvant radiotherapy. And then obviously the other part of my question is, what is the advantage of adjuvant radiotherapy?
Okay, I would say as long as the PSA is controlled and not rising in the post-operative period, up to an year, whenever we do the post-operative radiation, we refer it to as adjuvant radiotherapy.
Okay, Dr. Rahul, can you throw some light on it?
So I agree with what Priya has said. So till 12 months, if there is no PSA rise, and if we are giving radiotherapy for a post of pathological indication, like pathology indication, then it is adjuvant. But if there is a PSA rise, and even if you're giving it 3 months, it's a salvage. It's not a post-op adjuvant radiotherapy.
Okay. So
Apart from
why not the slide one? So the literature that I went through about understanding about the adjuvant radiotherapy, as Dr. Rahul and Priyamvada said, within 1 year it can be given. But it's not about the PSA only, because when you decide about the adjuvant radiotherapy, there is a parameter which is not guided by the PSA level. So when it is given early with no evidence of disease, that is within 24 weeks. The reason is that PSA has kind of half-life of almost 3 days. So it takes around 6 weeks or so to get neutralized. And the advantage of adjuvant radiotherapy is that it is possible that early treatment with adjuvant therapy might be more effective than a policy of delayed salvage radiotherapy for biochemical progression. Same I want to ask with the salvage therapy, which has already been discussed, that when there is a rise in the PSA, whether it is 3 months or late after that thing, then these patients are considered for salvage therapy. Nilesh, any comment about salvage therapy, when it has to begin and what is the advantage of giving salvage therapy?
Salvage radiation should be given as soon as there is indication that PSA is rising, PSA biochemical relapse at the earliest incidence.
Okay.
Hello.
Yes, I'm getting it. So PSA is
Yeah.
rising, and you have to give within 2 months of PSA biochemical progression.
Yes.
And it can be delayed up to 2 months if the patient is also due to receive hormonal therapy. The advantage of salvage therapy is that it avoids unnecessary treatment of those cured by surgery alone and can therefore result in less treatment-related toxicity. So what is biochemical progression? Please take this question one by one. Dr. Premvada.
In the post-operative period, the PSA is repeated after the surgery at around 8 to 12 weeks. If the PSA level is below 0.2, that is it to be controlled. If it is above 0.2, we take it as persistently high PSA. If the PSA was less than 0.2 in the post-operative period, but is showing a consistent rise, then it is taken as biochemical progression.
Yeah. Dr. Maulik, any add-ons to this?
Also, post-op, in situation of the post-op cases, 0.2%, 0.2 is the cutoff, I think.
So you more or less you agree with Dr. Premvada.
Yeah.
Dr. Samarendra, any add-ons?
So, sir, in post-op cases, it is 0.2 rise in PSA by 0.2, and that is compared from the pre-radical prostatectomy level. And for external beam RT, it is little different. It is rise by 2 ng per ml at any point of time.
Okay, so more or less, the people, all the panelists agree on the level of PSA. But when I was going through the literature, then they considered clinical progression or initiation of non-protocol hormone therapy also as biochemical progression, as well as death from any other cause also. So it was kind of a thing which I noticed and wanted to share with everybody over here. So, do all post-op prostate patients require radiotherapy? Samran, you just start this discussion.
Not all the patients, sir. There will be a category of patients where you require adjuvant radiotherapy, particularly T3, T4s, pathologically margin positives, node positive patients, high PSA, pre-RP high PSA. These are all patients which will require, not all patients.
So what is the value of PSA that you take it high for deciding about the adjuvant radiotherapy?
So it is only the biochemical recurrence we are talking about, sir?
No, pre-operative PSA. So
pre-operative PSA, any high risk, any patient falling into high risk category will definitely consider giving adjuvant RT.
So when the patient comes to you, what the post-op CA prostate patient comes to you, so what are the parameters based on which you decide about giving adjuvant radiotherapy to the patient? For example, patient cut margin is negative, all the parameters that you are suggesting. Do you consider pre-operative information for deciding about the adjuvant radiotherapy, or you need?
Yes, sir. That has an added advantage, placing the patient into high risk category. So definitely, I will like to evaluate what are the pre-RP PSA levels. Okay,
Dr. Maulik, any comment?
I would primarily see the pathological report and then go for the pre-op workup. Based on the pathological aspect, high risk features including T staging, T3, T4. Other is node margin positivity. All these parameters require adjuvant radiotherapy. In some cases where it is early T1, T2, we may consider for the pre-op parameters.
Okay.
So my primary data set for the deciding factor will be post-surgical histopathological report.
Okay. So if any one of the feature is present, then you consider those patients for adjuvant radiotherapy, or you need multiple factors.
So I think the seminal vesicle and extracapsular is T3.
Yeah.
Okay, and detectable PSA after surgery. That means we are talking about
I am asking if you have this one of the parameter is positive versus 2 or 3 parameters are positive. So you what is your thought process when you decide about adjuvant treatment? You want multiple parameters to be positive, or any single parameter is fine enough to decide?
My decision will be stronger with if multiple parameters are present, but primarily T3, T4 surgical margin and nodal positivity are 3 main factors which decides for the further adjuvant treatment or salvage.
Okay, so in the case we are having single node positive.
Yes.
Okay, so you consider this thing for?
I would consider for the adjuvant treatment.
You'll consider for this adjuvant.
Sir, in this setting, I would definitely require a pre-RP-PSA levels, because as such only node positivity is not a major factor, major risk factors. Definitely we have to look into other parameters also.
That information is with Dr. Manish Pandey.
Yes,
I don't know whatever was the pre-operative information. Dr. Rahul, any comment about these parameters?
I think all the trials under which these conditions have been described are for basically N0 patients. And in that, it is biochemical failure, and that is what the evidence is, coming up, that you should be treating with them with the salvage radiotherapy. For the nodal positive disease, what you are putting up today as a case, if I'm not jumping the gun, so we have to be careful because the evidence is not very clear cut.
Yeah, that's
although true. That is the commonest scenario in our working conditions in India. And if the patient has not undergone extended pelvic lymph node dissection, then as per the guidelines, it has to be 3-way options, whether observation or hormone therapy or hormone therapy with radiotherapy or radiotherapy alone, versus, if there is, sorry.
I'm listening, yeah, continue.
Yeah, so if there is no extended lymph node dissection, then the case is stronger for going for adjuvant radiotherapy in lymph node positivity. Now, I think one of the speakers was saying that 1 node versus 2 node versus more than 3 nodes. So obviously that is again described, but again, all the data is retrospective. So, it is quite left to our own individual biases to how we want to go ahead with that.
That's true. So I just brought that topic into I didn't want it to do at this point of time, but then because the nodal positivity was mentioned, so I just wanted to clear it. What is how one should understand about deciding about the adjuvant treatment when there is nodal positivity along with the other parameter that we are discussing. So these are the parameters that we have already discussed. Along with that, there are other parameters like postoperative PSA of 0.0 nanogram, 2 nanogram milliliter or less, along with the T3 stage Gleason high Gleason score or perioperative PSA of 10 million nanogram per milliliter also. So these multiple factors or few of the factors, when they are present with the patient, then obviously we consider those patients who post-op radiotherapy. And as far as the evidence is available, so these are the one of few of the important trials that one should know. How does it work? So if the seminal vesicle is involvement, there is 12% versus 36% 10-year PSA cure rate. And if there is positive margin, then the ratio is 49 versus 78%. And in this German study, in which was having 268 patients, the T3 stage, which is seminal vesicle and other things that we are discussing, 54 versus 72%. So these are the parameters that define about the that tells us about the role of post-operative radiotherapy if these factors are present on singular basis. So what are the chances of PSA relapse when these for example, these are the patients where the margins are positive, there are multiple margins positive, there are extracapsular extension, there is node positivity, there is seminal vesicle involvement. So as far as the chances of PSA relapse are concerned, we have different ways to understand. One of the way to understand and one of the simplified version to get the understanding about the chances of PSA relapse is to have nomograms. There are different nomograms which are available online. This is MSKC nomogram where we put all the factors into account, and then we try to understand what are the chances of PSA relapse, and that also helps us to decide whether how the patient should be given and when the patient should be given adjuvant radiotherapy. So, is it better to treat post-operative patients for high-risk features, or to wait and treat later if the PSA start rising? So this is 8-year specific survival data, which is having different parameters in terms of margins, in terms of Gleason score, in terms of nodal metastasis. And when we give immediate radiotherapy to these patients, then there is definite advantage of giving immediate radiotherapy to the patient, rather than delaying the patient and waiting for the PSA to rise. As far as node positive prostate cancer patients are concerned, at the median follow-up in this study, which was published in Lancet long back in 2006, in the median follow-up of around 12 years, there is significant improvement in overall survival. So all these studies, the previous studies, the studies which were around 10 years or 15 years ago, they used to advocate about starting radiotherapy as soon as possible, means in terms of adjuvant setting. But if we see the NCCN guidelines as of now in 2022, all these guidelines as far as NCCN as well as ESMO, the panel recommends use of nomograms and other things to decide about the adjuvant radiotherapy. And the indications for adjuvant radiotherapy is PT3, positive margin, subinnovesical involvement, and it has to be given within 1 year after radical prostatectomy, as Premada was telling, after the operative side effects has improved, which Dr. Nilesh was suggesting, and the patient with positive surgical margins, when start with the adjuvant radiotherapy, they benefit the most. So if these features are present, then these patients should go for adjuvant radiotherapy rather than considering the patient for salvage radiotherapy. As I was telling about the ESMO recommendations, the immediate postoperative radiotherapy after radical prostatectomy is not routinely recommended. The patient with having high risk features are the candidates for receiving adjuvant radiotherapy. So in our case, where the single node was positive, it is very soft indication of starting adjuvant radiotherapy if other features are not present. So how this data has come, it is based on so many factors, but the few things that I would like to discuss is about this meta-analysis, and which shows that there were 3 published randomized control trials, which shows that adjuvant radiotherapy to the prostate weight give better biochemical control than no adjuvant radiotherapy. How the results were inconsistent, and the outcomes were in terms of progression-free survival, metastasis-free survival, and overall survival. So therefore, the adjuvant radiotherapy was not universally recommended in these patients, and uptake of adjuvant radiotherapy has been variable. So these are the 3 trials, which is radicals, GETU, AFU 17, and RAVES trial. The endpoints in radicals is time free of metastasis. In GETU was event-free survival, and in RAVES was biochemical progression. So these are the different endpoints, but there is some statistical way when they ironed out these endpoints, and they try to understand what is the benefit of adjuvant radiotherapy and when it has to be given. So in this trial, if these are kind of uniform trial in terms of eligibility criteria, in terms of using hormonal therapy, in terms of using radiotherapy dose. Although in radicals trial there is hyperfractionation, there are subset of patients who have received hyperfractionation 52.5 grain 20 fractions also. But overall, the other trials have used 66 grain 33 fractions or 64 grain 32 fractions, depending on the way they want to deliver. So this is important cartoon in terms of understanding how the post-operative radiotherapy patients, post-operative prostate patients are being treated these days, and what are the doses that we were debating sometime in the debate. We were discussing in that debate, and when it has to be given for when we decide about the post-operative radiotherapy. So the results show that there is no clear evidence that adjuvant radiotherapy improved event-free survival Guidelines and policies should be reviewed with reflect to this evidence, and use of early salvage therapy following prostatectomy is the standard of care of man diagnosed with locally or locally advanced prostate cancer, rather than giving adjuvant. It means it is not advocating for the adjuvant radiotherapy. So the role of ADT. Nilesh, what is the duration of ADT that you follow in your practice when you are treating post-operative radiotherapy patients?
I prefer to give it for 2 years. The guideline is for 2 to 3 years. So the lower window is 2 years.
Lower window is 2 years or higher window is 2 years?
3 years.
Dr. Malik?
Sir, it is, can I come in, sir? It is actually 18 to 24 months. I mean, depending upon the risk category. If it is a high risk, then definitely the lower point is around 18 months, so around 2 years. And then the higher can go up to 3 years also.
Okay. Dr. Premada?
In our practice, we use two main criteria to decide on the duration of ADT. One is the Gleason score, the pathological Gleason score, and second is the pre-radiotherapy PSA. So if the Gleason score is less and the pre-radiotherapy score PSA is also less, then we may omit ADT altogether. If the pre-RT PSA is anything between 0.5 to 1.5, we generally add 6 months of ADT. And if
what is the basis? What is the basis of this rationale?
This is from a systematic review by Spratt et al. This was published in European Urology, and you can check that out. They have a nice table where the broad guidelines of implementing duration of ADT in practice they have recommended.
In post-operative setting?
In post-operative setting, yes.
Dr. Rahul, any comment about this?
Yeah.
So this is what we are currently following. This is all based on systemic and meta-analysis, not a level 1 evidence for sure, and that's not available. And that's why the heterogeneity. But if I have to simplify, it is basically at least 6 months if the node positive disease is detected and you have a salvage setting for that. But it has to go up to 2 to 3 years in general when you have large nodal burden or a PSA rise.
So my other part of my question is what percentage of patients in post-operative setting you get where they have received new adjuvant hormonal therapy followed by surgery?
Mostly they are operated outside. If they come like that. But in TMH, definitely no patient would receive new adjuvant hormone therapy before surgery. But yeah, so some percentage from outside definitely have already received new adjuvant hormone therapy before they go for surgery.
Dr. Nilesh, any experience about new adjuvant hormone therapy followed by surgery?
Yeah, in my practice, I am getting to see nowadays a patient getting 1 or 2 injections of GnRH analog or antagonist, and then undergone RP, and then came for referred for RT for some high risk features. Okay. So it actually, I don't think it is evidence based, but it makes the things very complex to understand ourselves first and to explain it to the patient.
Because the thing is that we need to patient asks us to follow the schedule of 3 monthly or 6 monthly, whatever hormonal treatment has been given to the patient. And when do you start hormonal treatment, if at all, if you have to give, you start whenever the patient visits your PD, or you wait for some time before starting hormonal treatment? Premada, you can take this question.
Okay, so generally in our practice, very few patients receive ADT outside and then the new adjuvant ADT, hardly about 10% or so. More common situation is after the surgery, 1 dose of ADT is given, and then we are not able to monitor the PSA in post-operative setting. The ADT is started with the radiation if we are doing it immediately in the post-operative period, and it is basically started with the radiation. I don't see any reason to wait till the radiation is completed.
Because what I have seen in my practice is if the patient has not received new adjuvant hormonal treatment, then the surgeon gives post-operative
Yes,
sort of
yes, exactly.
and then
So
patient
after
goes.
the surgery, the patient generally receives 1 dose of ADT and then comes to the radiation OPD.
Yeah.
And in that case, if this is a patient like this, our case, the node positive one, then we continue the ADT as such, and we plan for radiation in the next 2 to 3 weeks.
So the take home message from the discussion remains that minimum duration of ADT is 6 months, and you can extend up to 2 to 3
Preferably
years
longer.
depending on the risk features. Okay.
Sir, can I come in, sir?
Yeah, please.
Sir, the point we discussed right now, neoadjuvant ADT before RP, I mean, it is not at all totally recommended, but some of the patients do come with us after neoadjuvant. So the problem with neoadjuvant ADTs is not only changes the PSA kinetics, it also changes the biology. So that makes our decision very difficult whether to start with ADT as soon as surgery is finished. So one problem is that, and the second thing is all this ADT recommendation is based on the initial restratification of the patient prior to surgery. And if suppose the patient is requiring ADT and has undergone RP, then it becomes really difficult, because the restratification, according to stratification, if the patient falls into T3A or 3B, then and there you have to decide whether you want to go for surgery or you go to for EVR.
So if the patient has received neoadjuvant hormonal therapy, it becomes kind of an indication of adjuvant radiotherapy.
Yeah, obviously, sir.
Softly.
Yes, yes, sir.
Softly. Okay. So what is the technique of radiotherapy which one should follow? Nilesh, how do you treat, what is the technique that you use for post-operative radiotherapy?
I would prefer using IMRT based technique with the image guidance, minimum IMRT.
Okay. Samren?
So same as Nilesh sir said, IMRT with image guidance.
Maulik?
Yes, we met with IGRT.
So everybody agrees for this thing?
Yes, sir. I mean, rather than technique, I think the fractionation would be more important.
And the
of course, IGRT.
daily protocol of the
technique is very important, because if you treat this patient with IGRT, then there is definitely significant low toxicities. So what I want to understand, when you are treating post-operative radiotherapy patient, so one should go for image guidance if it is available, because it makes a lot of difference in kind of toxicity that patient gets with the radiotherapy. So the recommendations from ESMO is, as far as post-operative radiotherapy in prostate cancer is concerned, is about that immediate post-operative radiotherapy after radical prostatectomy is not routinely recommended. And American Society says that patients should be counseled, that high quality evidence indicates that adjuvant radiotherapy reduces the risk of biochemical recurrence, local recurrence, and clinical progression. And now, this is my last question to everybody. How do you prepare a patient? What are the doses and what is the target volume that you follow in your practice? Nilesh, please just quickly describe this. Hello? Am I audible?
Yes, sir.
Yes.
Yes.
Yeah. Samran, you can tell, how do you prepare your patient? Do you anything specific?
Sir, as routine all pelvic malignancies, we do the bowel and bladder preparations, and keep a particular position of the bladder, either moderate or full bladder, or you can do it the rectum preparation also overnight.
You follow standard bladder.
Those post-op setting will usually go with the conventional fractionation, 2 gray per fraction. You can go up to 64 to 66 gray. That is the recommendation. And target volume, if it is a post-op setting, with this particular case we are discussing node positive, I'll take the tumor bed and also the pelvic nodes.
Okay. Premada?
Yes, we also do a pre-RT IPSS scoring to score the urinary symptoms. It gives us an idea about the patient's urinary status pre-RT, and if there any change that happens during RT and post-RT, it is useful for monitoring. The dose I agree, we also use 64 to 66 gray in 2 gray fractions. We have been thinking of hyperfractionating, but we haven't changed the practice yet. And target volumes includes the prostate bed and the pelvic lymph nodes going up to aortic bifurcation.
In post-operative setting.
In post-operative setting, also we are going up to aortic bifurcation because we are using IMRT, IGRT. We have not seen any increase in the toxicities.
Okay. Dr. Rahul?
So I think why you're asking me is because the prostatic bed is only when it is N0 disease, but if there is N positive or high risk disease, then you will cover for the pelvic nodes also. Right. Is that what you meant to ask, Manish?
Yeah, yes. That's what because the case that I was given was I didn't find any juice in it. So just wanted to.
Manish, can I make a comment?
Yeah.
Manish.
Yes.
This is Kinjal here.
Yes, Kinjal.
So when we do 66 gray for the adjuvant RT, we give the pelvis, the nodal area. We don't give 66 gray to the nodal area.
Yes, the
obviously.
nodal area, of course.
Yeah, so we start after 50 gray.
Nodal area gets 55 and 32, which is equivalent to around 46 to 48.
Yeah, so just for just to understand, I just made it clear.
उतना confidently नहीं बोलती.
Yeah. Okay.
Sorry for
carry on.
So anybody wants to add to it? Actually, there are. I think Maulik
yes, sir. So that is okay,
sir.
sir. I mean, tumor bite we go up to 64, 66, and elective pelvic nodal irritation we go up to 50 gray, in and around 50 gray.
Listen.
Okay. So just wanted to. I want to. There was something that was there in my mind, but then okay. I think we are running short of time. So this is what we should think about when we plan about the adjuvant radiotherapy in the post-operative setting in the prostate. And I think I rest my discussion over here.